108 medical book chapters and almost 700 publications. He's an editor, associate editor, and member of the editorial board of several medical journals. And I've been very fortunate to serve with him on the Head and Neck Cancer Alliance National Committee, and that's where I got to know Dr. Brook. And he's doing some amazing work in terms of lobbying for our head and neck patients to get their voice prosthesis, electrolarynx, basic functional components that are not covered by healthcare. So Dr. Brook was diagnosed with larynx cancer in 2006, and 2 years later he had to have a laryngectomy, and he currently speaks with a tracheoesophageal puncture. He's the author of the book My Voice, A Physician's Personal Experience with Throat Cancer. And in fact, this morning he gave our department an inspiring talk on how it is to be a laryngectomy patient and what we as physicians should look for. Dr. Brook is the recipient of the 2012 John Conley Medical Ethics Award by our Academy this year. And once again, I would like to welcome him. This week is our Head and Neck Cancer Awareness Week. We have a free screening at the Cancer Center. And tomorrow he's going to be part of our voice club for our laryngectomy support group. So we've had a number of events. And today, interestingly, is World Voice Day. And so it's a perfect day for Dr. Brooks to be giving his talk. Thank you.
Thank you. It's a pleasure to be here today and talk to you about medical errors. First of all, I hope that you can all hear me. I have a low voice and I speak with a voice prosthesis. And here is a diagram how I speak. I'm by diverting air through a little prosthesis into the esophagus, and the air and the vibrations created allow me to speak. So this is my challenge, to be able to hold the seal that is gluing this device here around my neck, which allows me to speak. Well, I wanted to talk to you today about my experiences as a patient with throat cancer, and how I encountered many of those errors, and nursing and physicians while I was a patient, and how I suggest we can prevent those errors by better education, patient advocacy, and how we can improve patients' care. First of all, medical errors are very, very common. It's shocking to me, was shocking to me, when I became a patient, to realize how common they are. I've been a physician for more than 40 years, but I've never been on the other side of the stethoscope as a physician, learning on my own flesh the seriousness of those errors. There wasn't a day when I didn't notice at least 2 or 3 errors that were done by nurses, physicians, technicians, nutritionists. It was a psychological and physical strain for me to be on the watch all the time to try to prevent errors. It's a miracle that the patient get out without more damage than they came. And indeed, in surgery, it's estimated that about a third of all patients end up with some kind of permanent or temporary damage because of mistakes. Imagine how lucky I was as a medical professional that I was able to observe those errors. The layperson is much more susceptible to them and cannot even correct them. Many patients are intimidated, are so grateful to us that they don't voice their concern or criticism. And that's why we don't hear and we don't prevent many errors that can be prevented even when they are observed. People like myself who are having difficulty in speaking, especially after surgery when I couldn't speak for 6 weeks, are much more susceptible to such errors. Let me share with you first of all what I saw in my own eyes as far as the errors that I encountered. The first one that I noticed was that my physicians failed to recognize that my cancer had recurred, even though I came to them with complaints of pain. They relied on an imperfect physical examination, endoscopic examination. They relied on the fact that the CT and MRI and PET scans were negative, but there was no substitution to a good physical exam, which they neglected to do. What they should have done is ask me to do a Valsalva maneuver while they do endoscopy. Breathe here, hold it in, and then look. This allows parts of the upper airway, most specifically the piriform sinus, to open, and it reveals an area that otherwise is not seen. My tumor was already an inch long, and it was missed by CT, MRI, PET, and that is really the clue to diagnosis. Good physical exam. The other thing that I learned is that some of the mistakes made to me was because of the physicians' lack of experience. They offered me a procedure which they have only done once before. Consequently, I didn't get the right treatment and I got therapy for another patient in one of the best centers in New York. So you can see, even in the best places, mistakes do happen. And these are just some of the physician's errors. Nursing errors are more common. They range from not responding to calls to forgetting to connect the bottom on the bed. I was in ICU one day after my laryngectomy, 3 feet away from the nursing station. I was connected with 5 different tubes, IV lines, catheters, and suddenly I was choking with secretions. I couldn't cough it out. So I looked for the buzz to call the nurse to save money. The same nurse was serving 2 ICU patients. My nurse was away. I couldn't call for help. I disconnected my PO2 monitor. Nobody came. I disconnected the EKG. I thought maybe they'll see a flat line. Nobody came. Fortunately, my wife just happened to come in the morning, and she called the nurses to suction me. Imagine this can happen in ICU. You can choke to death. Not every hospital has one nurse for 3 patients. The first one I went to, military one, had 1 per patient. But in that hospital in New York, they were saving money. And so here is an example of a nursing error. Some of the errors are listed here, like not washing hands, not covering the thermometer with a plastic, using the improper blood pressure cuff, leading to alarming results that meant that I got medications to lower my blood pressure, which wasn't high, and administering the wrong dose of medication. So these are some of the mistakes. Now, to prevent errors, there is a lot that can be done. One should use better methods and uniform methods for training. I think we skipped some slides. What's important is to adhere to certain standard of care. The rule now is to use algorithms. Algorithms have been shown to prevent correct and tell you if something went wrong. It's from the beginning important to ask friends or advocates to help patients make the right choice so that mistakes are not being done. Encourage second and even third opinion. Is nothing demeaning about it. It will also make the patient know that you are there to help them choose the right treatment. What patients should do is look for the experts in their field. Sometimes patients make mistakes by confusing friendliness with expertise. I made those mistakes. My physicians were lovely human beings, but still they didn't have initially the best expertise in my field. And ask for the true prognosis. Don't ask for the optimistic, but for the realistic approach, so that if things don't work right, the patient should know and recognize it and accept it. What I tell patient, and you should encourage them to do, is to give you the best straight story. Everything, the more you know, the easier it's going to be to prevent errors. All the past and history, all the little nuances, they can all help you make the right choice. Also, what I ask the patient to do is to challenge us. Ask questions. Don't let them be dismissed. Don't overshadow them. Let them ask. And I also think and tell patients, don't assume that we, the doctors, know everything, because we don't. Medicine is as much as art as it is a science. If the patient is an advocate, they are going to be more likely to catch errors and explain and ask questions, especially when the patients are obtunded or sick or voiceless, have a friend or family member be there and challenge. Surgeons and us, also internists, need to be patient. Listen to the patient. We are all overworked, but you need to recognize how overwhelmed the patient is. They cannot always make good judgments. That's good. They want to be saved and helped, and they don't always ask the right question. You need to let them have time to question you, challenge you. The more explanation you give, the better they'll be in helping when I asked my surgeon to listen to my lungs, he said, I really would not even know how to do it. Let me call the internist. I was really shocked, but at least he recognized his shortcoming. So you need to remember, the patient is made of body and mind. Don't forget to think about the patient's psychic as well, and in other measures, dental, psychological, they all contribute to what we call the whole patient. It's important to recognize those issues and educate the young generation, the residents and fellows about those issues. Residents follow us. They attending. If they show us, see us attending, be patient and concerned, they'll do the same as we. That's why it's important to follow those guidelines. I'm changing my prosthesis so I can have better voice. But what's important to educate the young generation to make sure they develop good treating habits that will care for the patient, that will catch errors and be more humane and caring. I summarized all and a lot of what I talked about today on my blog, which is listed here, where I talk about medical errors. I have also a page there that talks about how to prevent it and what my experiences were. I know it's a difficult and sometimes challenging topic, but I think that you can, by encouraging better adherence to standards of care and patient vigilance and advocacy, you can prevent many of those errors, getting to better results and better patient satisfaction. I'll be happy to. I want to thank you for your attention, and I'll be very happy to talk to you and answer your questions. Thank you. Yes.
One of my observations about this, and thank you for presenting this, I agree with everything that you said, but we have several obstacles that we need to overcome. My observation is that one of the major problems with medical errors is that most people either don't care or think it's someone else's responsibility. And as a result, we abdicate our responsibility to someone else. In terms of the younger generation, they need to learn to feel confident enough that they will allow patients and their advocates to challenge us, because there are many physicians who are either overly self-righteous or are afraid that when they're challenged their entire being is being challenged and don't feel confident enough to have a discussion like that with the patient or the advocate.
You are correct. Many physicians feel threatened. Many today with the internet, there is more knowledge. Many patients know a lot about their illness, and I think the more they know, it's better. On the other hand, there is also a lot of false information that patients have through sources of knowledge that are not perfect. And I think we should encourage it. I don't think we should see it as a threat to us to get patient challenges. I can tell you that as a patient, I was afraid to challenge my physicians. I was so grateful initially that they are taking care of me, that I was afraid that if I would challenge them, they won't give me the best treatment. Yeah, it may sound strange, but I was afraid. I was afraid that they will label me as a troublemaker, so I kept silent. I was silent anyhow, but I at least didn't say anything in writing. And as the mistakes accumulated, I realized that if I don't speak out, I will not get out of this place as healthy as I could. And I started to speak out. My luck was that my daughter was my voice for a while until she had to leave, and she was my patient advocate. But many patients are threatened by us, even if we are non-threatening. But we can try to disarm them and tell them and create an atmosphere of less threat and encourage them to talk. Instead of being defensive, we would say, okay, well, let me look into it and let me do something about it. One of the most humiliating episodes that happened to me when I was recovering from my laryngectomy was that one morning residents were making rounds, and my tube, I had a laryngectomy tube, was completely clogged with mucus. The nurse usually came and cleaned it, but she didn't. The residents got in first, so I asked the resident to clean it. I was shocked when he took it out without gloves, went to the faucet and flushed it with water. I refused to let him put it back in my trachea, in my tracheostomy. I wrote to him, this is not the way. You should clean it. You have to open a kit and do it. He said to me, we are running the show now. Well, that's how we do it. I didn't. I was so helpless. I couldn't do anything except refuse him from doing it. And when I mentioned it to the attending when he came, he told me, oh, this resident is very nice. He has never behaved like this. I can't believe it did it. And I didn't hear anything more about it. So, it was an example of a mistake. You don't clean it with tap water. You have a kit. You need to wear gloves. And this is an example of arrogance. That is no room. Now, if I was a physician, if I could walk, I would go to the hospital director and complain. But I was a sick, helpless patient. And here is an example how a patient can do anything. And he's completely at the mercy and also many places employ nurses that are not as well trained. I noticed that in the middle, when I was in Walter Reed, a patient in Walter Reed, it was then an Eagle Hospital in Bethesda. Nurses were young, but very well trained. Everything was done according to the book. I went to Walter Reed, which is an army hospital. Doesn't exist anymore. It was about 2/3 of the nurses were civilians from all over the place. Some were good, but some were not. So what happened is that there was difference in education. Some nurses were well trained, some were not. And you need to make sure that everybody is following the same procedure, and that will prevent mistakes. Yes.
Thank you very much for this eye-opening talk. I think you need to go around the whole country to teach us about this point, which is just the tip of the iceberg. You are an insider, you are a physician, you know what's happening there. So the problem is big. I have a job that I don't use much. Don't go to the hospital, particularly when you're sick. The problem is the education at all levels that you mentioned. To be critical, you have to suffer hate. People like to be praised all the time. You are doing a good job. You are doing a good job. Even if you say it 10 times and one time you say that's wrong, the 10 times that you praise will be deleted. And I'm glad that you will not flag inside the hospital, because people around you say, oh, he's pain, because you are corrected. So it's coming from high school, to college, to medical school, to residency, fellowships, and so on, and you are getting be nice. We are not critical, and therefore we are suffering now. The problem is big.
I couldn't agree with you. It's important. At one point I said, enough, guy. I'm not going to be a nice guy anymore. I was going to take the gloves stopped. But I am extremely grateful to everybody, and I say it to them. But on the other hand, I realize that we are all human beings. We all make mistakes. It's not a perfect world, and the only way we can prevent it, reduce it, is to have a checkpoint. We have a system that reduces it. That one thing is to have less burden on physicians, less burden on nurses, until they are not overwhelmed, so they don't make mistakes because they are tired and overworked. And we also have a system where people are encouraged to admit and discuss openly, so that you don't repeat it. We have in our hospital now a system that we meet once a month and we talk about the mistakes we made, without accusing anybody, without reprimand, just to talk, to prevent the errors from happening again.
Thank you so much for your discussion. Your words humble us because you speak both as a patient and a physician, so we have to listen to what you're saying. The part I really found most important, I think, for our young doctors is something that we have to emphasize over and over, is the importance of Voorhees' novel, Cutting for Stone, where it talks about a fool with a tool is still a fool. And sometimes we have to remind ourselves that just because we are CAT scans, it's not the same as going and talking and examining the patient. And I think your words are very important. I hope the younger doctors and us older doctors will appreciate it.
I agree with you that we forgot the art of medicine. Over the years, I remember when I went to medical school in the 60s, how my teachers were really true clinicians. They could examine the patient and listen to them and talk to them, and they were able to find things that today people forgot how to do it. The art of medicine. I believe that even today, that 95% of the diagnosis is history and good physical exam. And unfortunately, the new technology made us rely on tests and scans. And in this way, we even spend less time with the patient. And that also, of course, leads to mistakes.
I appreciate your story. I think several of us here who have been patients also have experienced mistakes. And I wanted to ask you about the nursing staff. As someone who went to a Mecca for open heart surgery, I observed numerous nursing mistakes, consistent mistakes. And then I recently had a pacemaker put in. I've had an ablation. They told me not to move. The call button wasn't there. I was afraid to, well, if you're lying there and you think, I've got to go to the bathroom, they tell me I can't move. How long can I lie here and do this? And you're completely helpless. Mine was not as life-threatening as yours was. But the point that you made, I was afraid to complain, thinking it would be worse if I did. And the question I have for you is, with cost being such an issue now, I think there will be less and less nurses. And so what are we to do with less staff when there's still a need for eyes and attention?
I really don't have an answer. I think there is no substitute for hand-on. When somebody is out of the ICU, out of surgery and in critical condition, you need a person there. I don't think there is a substitute, but there is also some negligence. I wrote about those episodes in my book. There was an episode when I had a skin flap removed from my hand to create my new esophagus, and that flap needed to be covered. The nurse was removing it and left me alone in the room because she had something else to do. I was lying there. For me, it looked forever. 20 minutes. Couldn't call for anybody. When I finally got somebody, they told me the nurse is on the phone ordering something. A physician who came to try and do it. The resident was called by an attending. Nobody seemed to care that I had tremendous pain. For about 25 minutes. There is simply sometimes pure negligence that happens in those places. The only thing I can tell you that a patient advocate is so much needed. I know that if God forbid anybody of my family will be in the hospital, I will not leave their sight 24 hours a day. Fortunately, it didn't happen to me yet, but I think if it will, I will not leave
nurses have forgotten what their training has been. And everybody is focused on getting work done as quickly as possible so that they can get on to the next thing. And it's left the medical professionalism in the dirt.
I agree with you. People are so overwhelmed. Sometimes I wanted to talk to a physician, and he told me, write. I couldn't speak. He would dismiss me and say, I'm really very busy, I have to run to my clinic. Or I have to run to the OR. Have your wife call me later. I had one mistake that happened because they wrote an order for another patient in my chart to start feeding me after a week after the surgery. It seemed to me very strange because I remembered that my surgeon told me that I will be starting feeding 2 weeks after the surgery. I protested, but then I said, well, maybe I'm happy to eat again. And then, only because I questioned it again and again, did they finally stop it. 12 hours later, when they realized they made a mistake, I was fortunate that no bad thing happened out of it. But after getting my type of surgery, it was dangerous to eat too soon. Here is an